Hi everyone, can you all hear me?
Yes.
Yes. Yeah.
Welcome to today's talk on palliative care in dementia. My name's Dr. Carolyn Berry. I'm a GP working in Your Health Partnership Primary Care Network, and I also work for the Connected Palliative Care Hub as a palliative care doctor. I'm just going to introduce our speakers today. With us, we've got Dr. Aaron Saini, who's a GP partner at Portway Family Practice. He's going to start today just with a background to dementia, diagnosis and issues within general practice. We've then also got Amy Williamson, who's a dementia lead nurse at Your Health Partnership. And she'll be talking about her role and also her links with the Dementia Care Navigation Service in Sandwell. Unfortunately, the representative from that team is unwell, but so she'll be explaining their role as well, which will be great. And then we've got Dr. Anna Locke, who's a palliative care consultant, who will be discussing symptom control in dementia. There'll be opportunity for questions. So if you do have questions that you want us to answer, feel free to write them in the chat or during the question and answer time, then you can just raise your hand. Just to let everyone know, we will be recording this and we'll send a copy of the recording after. Please can you all mute yourselves during the talk, and as I said, any questions in the chat. So I'm going to hand over to Dr. Saini, if that's okay, and he'll make a start. Thanks.
Hi. Good afternoon, everybody. I think Joyce had a hand up, I think, before we started. Is there any questions, Joyce, from yourself?
No, I was just saying that I could hear the conversation that was going on. Thank you.
Okay, thank you. Hi. Well, good afternoon, everybody. I think as I've been introduced, name's Aaron Saini. I'm a GP in Albury and also a clinical director for Citrus Health PCN. And here, just to put a little bit of context into palliative care in dementia and why it's a challenge. So just some of the simple statistics that we just start with. We know that dementia is a growing challenge. It's nearly 700,000 people in the UK. It's got a prevalence of approximately 1 in 11 in over 65-year-olds. We know it affects the elderly. The likelihood of developing dementia doubles every 5 years. So you're more likely to have twice as likely to have dementia at the age of 70 than you were at 65, and the same way up 75 compared to 70. In 2022, dementia was the leading cause of death in England and Wales. It's overtaken cardiovascular disease. By 2030, we're estimating there's going to be over 1 million people in the UK that will have dementia. We know that deprivation, Sandwell and the Black Country are the second most deprived ICB in the country. Sandwell's the most deprived place and borders Birmingham, which is the most deprived ICB. We know that they have a high proportion of deaths of people with dementia between the ages of 65 and 74 is in these deprived areas. We know that, say, for example, from 2022, 74,000 people died with dementia. This is estimated to increase by 5,000 people in the next year. So that's from 74 to 79,000. And we also know that deaths in dementia is expected to triple from where they are now to approximately 220,000 by 2040. So we know that this is to bring a bit of context into the statistics, the challenge about what we'll be facing and what patients and carers will also be facing. There is an interesting, we know that there's dementia, and living with dementia and dying well with dementia has been a long-standing issue for the NHS. So the quote I have is from 2012, and we've got, work and papers that go back to early in 2006, 2004. I think it's quite, from a daughter of a person with dementia, is that I think at the end, it wants to be, so the person is least stressed or upset and in as little pain as possible, so they can be calm and go with dignity. When they get to the point of no return, as it were, I think they should be allowed to go peacefully, not be mucked about with unnecessarily. I don't think any of us would challenge any of those statements. I think the big part in there is dignity and choice. So if I just go back to here, I think we have is that we want the person's symptoms to be controlled. We know that they want to be peaceful. They're not to be mucked about. This is what we know that patients and people with dementia are saying. Let's go to the next slide. So this is what people, so this is from the Prime Minister's Challenge, again from 2020. What do people with dementia, what is their preference? What are they saying? They want to have personal choice and control over the decisions that affect them. They want to have the knowledge to be able to get what they need and make their decisions. And they also want to be confident that their end of life wishes will be respected. They want to have a good death. Again, I think these are all things that we would think are basic and that everybody should have. But we know that in dementia, this is not happening. Let's go on to the next slide here. We know that NHS England has had the WELL pathway for dementia. Sorry, it's a busy slide, but it's very easily available and everybody can look it up afterwards. There's a number of 5 columns at the top, and that we tend to use in general practice the most. And I think this is where we need to be concentrating. They are preventing well, diagnosing well, supporting well, living well, and dying well. We've got some facilitators at the bottom: researching well, integrating well, commissioning well, training well, monitoring well. I think these all facilitate the upper 5. These are the cornerstones to the pathway for dementia. Even though today we're looking at the last column, which is dying well, you know, people with, we can read underneath it, it says people living with dementia die with dignity and in a place of their choosing. We know that to achieve this, we have to discuss the options early. We can see where we are here, diagnosing well and supporting well. That's where we know that we will be looking at making those decisions. To die well, we need to discuss it early. We're looking at this, some things that we know that will facilitate this: care planning, lasting power of attorneys, advanced statements, advanced directives, which we're all going to talk about later. But these are all essential for us to ensure that a person with dementia has a good death. I'll go into this. So some of the issues that we have in dementia, we know that in UK culture, you know, none of us like talking about death. It's a taboo subject. We're not confident in talking about it. Patients and carers don't want to talk between themselves. Healthcare professionals find it difficult to broach the subject. It's something that we need to overcome. We can raise awareness and reduce the taboo. As I talked about care planning and proxy decision making, we're going to discuss this later, but this is all essential that we need to cover. Dignity. We know that this is what patients have said. This is what they want. We need to control symptoms, pain. Nobody should be in pain. We should be able to recognize when somebody with dementia has pain. We don't want to say, oh, they've got you know, aggressive behavior, etc. Some patients may not be able to tell us why they're in pain or they communicate that decision. When we need to withhold and withdraw treatment, you know, we need to ensure that any treatment or any intervention that we're making has some positive benefit. Patients' emotional and spiritual concerns, we need to make sure these are addressed. The place of care, where does the patient want to be? Where do they want to die? Who do they want around them? What sort of things do they want? I think the other thing in general practice, we're very good at identifying end of life and palliative care for cancer. I think we're getting much better at it. We're also other physical conditions. We're getting much better at it. Heart failure, COPD, persons moving towards the end of life stage. But again, with those patients, they still have their mental capacity. They can make their decisions. Dementia is a different kettle of fish. We really need to have those decisions made earlier so that the patient's wishes can be fulfilled. So I think we can work on frailty, we can work with MDTs, we can work with the Sandwell with your local dementia service to help support patients and their relatives and healthcare professionals. That's sort of the end of my talk, just of setting the scene. I'd like to probably pass on to the next speaker or the chair.
Yeah, thanks, Dr. Saini, for that. I'm going to pass, we're just going to switch slides. I'm going to pass to Amy in a second. Just a little addition to what I said at the beginning. There will be a feedback form which Dr. Locke has shared in the chat. So if you can feedback at the end, that would be really great. And Amy wanted me to let you all know she's suffering a little bit from a chest infection, so bear with her. She has to catch her breath, bless her, as she's talking. So I'll hand over to Amy in a second. The slides are just coming. If anyone's got any questions in the meantime, feel free to write them in the chat, but I think we're just about there. There we go.
Hiya, so my name's Amy Williamson. I'm one of the lead general practice nurses for Your Health Partnership. And I'm also the dementia lead. So I've been practice nursing now for about 14 and a half years, and I've been dementia lead since 2012. So in 2015-16, I undertook a foundation degree at Worcester University in dementia studies and research, and this was really to embed the practicalities of looking after patients from diagnosis to the end of life. Over the last 12 months, I've been working more closely with Dr. Caroline Berry, and I've got real interest in trying to improve and having conversations with people living with dementia and their family, improving advanced care planning for those patients. So I was going to have one of the dementia advisors, Jo Pegler Hadlington, here with me today, but unfortunately, from unforeseen circumstances, she's not able to make it. So because I'm going to be referring to the Sandwell Dementia Community Service, I just wanted to give a little bit of an overview of what they do and how you refer to them, so you've got an understanding of what I'm talking about when I do refer to them. So the Sandwell Dementia Community Service, they look... Oh, hi. Somebody said hello. Oh, sorry. Yeah, so the Sandwell Community Dementia Service. So they look after patients from diagnosis up until the end of life. They also, after the patient with dementia has passed away, they also give some ongoing care to the carer until they say otherwise. So so with the Sandwell Dementia Community Service, they cover the Sandwell Borough, they cover 6 towns within Sandwell. So they have 2 dementia navigators. So once the referrals are either made from a self-referral from patients or a referral from professionals, they will go to the dementia navigators. So then the 2 dementia navigators will contact the patients. They will do some initial assessment and some fact finding to see what that patient's needs are. Once that's been done, they will then, and the dementia advisor will follow that patient from diagnosis through to end of life, after giving that carer some support once the person has passed away. So really, with the Dementia Navigator service, they really bridge the gap in care, because as clinicians, we'd like to support patients much more, be a little bit more on tap to speak to patients with dementia and their families, and we can't always do this. So it's reassuring for us as clinicians that we know that we've got a dementia advisor that's allocated to that family, that can start to begin to build up a rapport, offer multiple services within the community, and also they will start to talk about advanced care planning, and they use a handbook called My Future Care Handbook, which is quite a lengthy document, but it's something that they can work through. We haven't got to rush advanced care planning. We need to start to plant the seeds and start to normalise the importance of having some of these conversations. So considerations in advanced care planning. So advanced care planning is something that we should all think about with our patients, despite whether they've got dementia or not. We should start thinking about what's important to us with our health. If things were to change and deteriorate, what would be important to us? What care and treatment would we want, wouldn't we want? Nobody knows what the future holds. Nobody's promised tomorrow. But I think as clinicians, we often feel uncomfortable about broaching these conversations, and we often can describe them as difficult conversations where really we need to move away from this ethos and start portraying to patients that actually these are really positive conversations, and it's a golden opportunity to start to share what's important to you. What's important is quality of life. What treatment would you want? What treatment wouldn't you want, depending on your situation. So particularly in dementia, starting advanced care planning is really important due to the nature of the disease and the progression and that cognitive decline. It could become harder for the person to understand, retain information, make decisions and communicate their wishes. I think it's worth bearing in mind that sometimes, even though we get a new diagnosis of dementia, that person could have been living with dementia for some time. So it's really important to still have a person-centered approach, involve the person living with dementia as much as possible, but equally drawing on people that are close to them, what they know about that person, what the person might have relayed in the past about what they would want in regards to care and treatment. So approaches to advanced care planning. So in primary care, we review our patients living with dementia once yearly, but what I try to do is that once a patient has been diagnosed with dementia, is try to see them about 8 to 12 weeks following that diagnosis.
One little problem.
Okay,
Hello?
so
It's Dr. Singh from West Bromwich. I just want to make a point that in spite of our best effort to explain to the patient about the deterioration in the health toward the end, people still panic a lot actually. I mean, even we tell them that, this is a normal process, but they're still trying to ring the 99 or ring the ambulance. It's very difficult for them to really go through that sort of experience at that time, in spite of all the ACP discussion, what not, what expected, etc. Any comment?
Yeah, I mean, I think as well, it can be patients still do have that fear about if they become well, and they might panic and phone 999 and so on. And that's why it's really important to have services, particularly with patients that living with dementia, the dementia advisors, because they are more accessible to patients, and they can call them and say that they're concerned about certain things, and the dementia advisors will liaise with GP practices, and I know they're being more proactive with wanting to speak to palliative care teams, because sometimes as well with patients with dementia, they might not be having symptoms that are palliative related, but they've got more concerns and they need that emotional support, which can be offered through the Dementia Community Service.
Thank you.
Okay, yeah, so just moving on. So I just wanted to just address some of the approaches that I take when I'm reviewing patients with a diagnosis of dementia. So like I was saying, that I try to see patients about 8 to 12 weeks after their initial diagnosis. So within this first review, I do broach the subject with advanced care planning, and I tend to do this by having an open question. So I will say to the patient and their relatives, has anybody ever spoke to you about advanced care planning, and what's your understanding around this? And then that sort of leads the patient into talking to me about, yeah, I have got a little bit of an understanding, or actually I haven't. And then I can expand on these conversations further depending on what the patient's ready to talk about. They talk about the progression of dementia, as we know that it's an incurable disease and it's going to progress over time. And I don't think that we need to always talk about resuscitation at that first point of contact. It's about planting the seeds about what's important to you. Is it as living as long as possible? Is it that quality of life? And discuss that further down the line as dementia deteriorates, it might be that you don't want other interventions such as resuscitation or certain treatments or investigations. And I think we just need to realise that we can revisit these conversations as we review the patient, and also utilising the Dementia Navigator service where they're seeing the patients much more often, and they can recognise when things are changing, have those conversations, have a good relationship in primary care with the Community Dementia Navigator service, because it really does help in managing these patients. So just wanted to talk a little bit about documentation of advanced care planning. So I think sometimes we're not so good at sharing when these discussions have taken place in regards to when somebody's been in hospital in acute care, and they might have had discussions, and they might have a DNA tech put in place, but then that is not transferred home with that patient. And equally from primary care, not always picking up actually on the discharge letters that these conversations have already been had, and we could revisit that and make sure that everything remains the same for the patient, and to make sure that we've got that documentation in the patient's home. So an example of this is that one of my gentlemen, he was in his late 80s. Dementia had advanced quite a lot, but he had a lot of other health concerns as well. And he'd recently been in hospital, and advanced care planning had taken place in there, and a DNA tech had been put in place. Unfortunately, that didn't come home with him, and within the same week, the patient deteriorated, collapsed, paramedics was called, and CPR was carried out. And that was really quite traumatic for his wife. I spoke to her, and that memory at the very end of him having CPR has really caused some trauma, and she's going to have some counselling to help her get moved past that. So in terms of documenting in primary care, so what we've done is within our organisation is we've designed a template which is based on the principles of the respect form. So when we start having these conversations with patients, and some of that advanced care planning has started to be completed, when that patient's notes is opened, it will flag up that this patient has an advanced care plan. So when clinicians are looking at that patient's record, or there's been changes in that patient's condition, they can say, oh, they've got a care plan, it's in one place, what's already been discussed, do we need to move things on further? In terms of looking at, does this patient need to be added to our palliative care register? Do we need to refer this patient into palliative care hub for more supportive care? So recognising deterioration is really important, and I find that continuity of care really helps with this. I know it's not always possible to see the same GP or the same nurse all the time, but if it is that you can appoint somebody within the practice to be the dementia lead, dementia coordinator that sees this patient, whether that be a nurse or a GP, then you get an understanding of what that patient's like at their baseline. And then when you're reviewing them throughout the journey, that you can recognise that deterioration, or when things changes, and start thinking about, should this patient be on our palliative care register? I mean, it could be argued that patients with living with dementia should be on our palliative care register, as it's a condition that's progressive and not curable. And sometimes it can be difficult to address with patients why that you would consider referring them to a palliative care hub or adding them to the palliative care register. And again, I feel it's your approach, because when we think about palliative care, when patients hear that word palliative, they tend to think that death is imminent, where actually, in fact, it's about getting the right support at the right time. We know that things have deteriorated. We know that you're having more admissions into hospital. Patients might express, I don't want that, I don't want further investigations, I want to be at home. And that's where we can pick up on these cues and make those referrals and have that integrated approach to care to support that patient at the right time. We can also use things like the SPIC tool and the GSF prognostic tool to help aid us with our clinical judgment, really, looking at those prognostic indicators. Has this person been having readmissions to hospital? Have they deteriorated in terms of their swallowing, their cognitive functioning is declining further, and this can help us. So I think it's really important as well. I think nurses play a fundamental part in looking after patients with dementia, because even though the nurses might not see that patient for their dementia review, they often see the patient for many other conditions like COPD, diabetes, chronic disease, or that patient might have leg ulcers and so on. And nurses are really good at building relationships with patients and recognising when there's things that have been changing in that person's care and health, and they can flag that up to other members of the multidisciplinary team to say, I think maybe we should start having more conversations and inputting more care for these patients. Again, just as well, utilising the Sandwell Dementia Community Service, having that reassurance that that patient living with dementia and their carers have got accessible care, they've got a point to call, somebody that they can contact, because it might not be that there's physical changes, or it might not be that they need to see a GP, or if they're on the palliative connective register, they might not need support at that time from those people. It might just be a more emotional support, or just want to have a chat really about what their concerns are. And then, as I mentioned earlier, about the dementia advisors using the My Future Care handbook to try and embed some of these conversations and what to expect further down the line as the dementia progresses. So there's just a couple of case studies that I just wanted to share, really, which just demonstrates how working together, palliative care services, primary care, secondary care, and outside organisations such as the Community Dementia Service can really have a positive outcome for patients. So I'm not going to read all this out word for word, so I'm just going to give you a quick overview. So this lady was an 87-year-old lady, and she had moderate Alzheimer's disease for some time. She did really lack insight into her difficulties, and she wasn't very accepting that she had dementia. She didn't think there was anything wrong with her, which could be quite challenging really for her husband and her family when they was trying to input care and support for her. So this lady was referred to the Sandwell Dementia Community Service from diagnosis, and Joe, our dementia advisor in Rowley, really supported this patient all the way through from diagnosis to the end of life. So she did start to deteriorate. She had started having a few falls, and then she was admitted into hospital with quite a serious infection. And this was really a big step back for her. When she was discharged from home, she was unable to walk. Her appetite had gone down, and she was bedbound. When she was discharged, because we'd spoke a little bit about advanced care planning, and I knew for a fact that she didn't want to go into hospital necessarily. She had a fear around going into hospital. She wanted to stay at home. That's where she wanted to be in her end of days. And when she was discharged from hospital, the GP did pick up that things had deteriorated quite a lot, went out to see her, referred her to palliative care, and did the DNA RTEP, advanced care planning, and then the dementia navigator supported her and went through the process of what's happening, what might happen next, and also was able to liaise with me. I was able to liaise with the GP and email the palliative care hub if there was any concerns, because particularly for this patient's husband, the fact that she wasn't eating and that reduced really caused him a lot of stress. He was worried about about her starving, basically. So it was just helping him, using all these services to help him understand what was happening next. And this lady did die at home peacefully with her family around her. And I just think it's a good demonstration that if we all work together as part of the MDT, we can support patients and their families a lot better. So the second case study, so the community dementia service wasn't actually involved with this lady. They was quite an independent family and they didn't really want much support. They was quite happy doing their own thing. So this lady had moderate vascular dementia and she lived at home, and she initially had a package of care, just 1 call a day. Unfortunately, she had a fall and she fractured a hip and spent some time in hospital. When she was discharged from hospital, she had a catheter in situ, which was causing her quite a lot of problems. She was getting reoccurring infections. She had urosepsis. She was going back into hospital. They was looking at other things to do with her heart and whether they should be doing further investigations for this, which was really causing her a lot of distress and causing the family a lot of distress also. So I happened to go out to see her just for a general annual dementia review, and I recognised that there was a lot of deterioration. And then talking with her husband and her daughter, and they'd been explaining what had been happening, how she'd really gone downhill, wasn't really eating or drinking, catheter was causing a lot of problems and discomfort. And that's where I brought up the subject about, did anybody have any conversations about advanced care planning, and do you know what that means, and then was able to elaborate further. So the daughter did have some understanding about it and was able to go into the kitchen, sit down and start to have these conversations. And like I was saying before, we don't need to rush everything. Patients need time and their family need time to process what you're explaining to them. So what we did was we started these conversations, and then the following day I arranged to go back and we discussed a little bit more, and there was quite certain that, one, they didn't want her to keep on going into hospital. She had expressed herself, I'm tired, I've had enough, I don't want this. And also the catheter was a big issue because there wasn't really any rhyme or reason why she needed this catheter, and that was really important for her to have that removed. So I was able to speak to the GP, speak to the district nurses, and was able to get that catheter removed. I was able to speak about referring her to the palliative care hub and for them to get further support as things were deteriorating, and to assure that she could remain at home because that was her wish and her family's wish. So this lady, she passed away about 6 weeks after that initial advanced care planning, with a family beside her. And quite recently I've spoken to the husband just to check in to see how he's getting on, and he said to me, you know, I'm really grateful, Amy, that you started having those conversations, because we'd been in and out of hospital looking at other investigations that we felt wasn't necessary due to a deterioration, and he's really been able to process losing his wife and come to terms and start that grieving process. So take home messages. So advanced care planning is a work in progress, which can take time. I think as clinicians, we need to not think that we need to rush and get everything done all in one go. We could just start planting the seeds, talking about what's important to you, looking at LPA and those sort of things, and then move on. If we rush these conversations, patients will feel that we've got a task-orientated approach to this, and that we're not really thinking and caring and about their actual needs. So communication, empathy, care and compassion is key. If we can be more empathetic, take time and really listen to patients and their family, they tend to feel more, what's the word? Well, they tend to do better, and they will open up to you more and feel that you've actually got their interest at heart, rather than feeling that you need to just get all this done. So continuity and familiarity is important for patients living with dementia, and I know that's not always possible, but I do think it's good as a take-home message that if you've got somebody that's interested in the practice, whether that be a nurse or a GP, that perhaps lead on looking after our patients with dementia, and again utilising the Dementia Navigator service, building up a good relationship in primary care with them, because we know they're getting that ongoing continuity of care from diagnosis to the end of life. So finally, I just want to say it's not what we say, it's the way in which we say that it's important to support our patients to engage in advanced care planning. Thank you.
Thanks so much, Amy. That was really helpful. I just want to quickly comment on a couple of things. Obviously, I appreciate we're giving this talk within Sandwell and we're referencing the Sandwell Navigation Service and the Connected Palliative Care Hub. I appreciate that some of you have joined us from outside of area, and I know there was a comment about the Scottish Highlands. So obviously, I guess the reference is that we need to utilise whatever MDT we have, and you may not have an MDT, but nonetheless, the advanced care planning is important, but just being aware of what services are available in your area, I guess, is really important. Has anyone got any questions? We'll have a quick look through the chat as well, see if there's anything else. If you have, please either raise your hand or pop your question in the chat. The 911 call, sometimes unaware family. I guess just to respond to that, it's obviously that's why it's so important to involve your family, the family members in these conversations. So sometimes it can be helpful to pre-plan a conversation to get the key family members in and make sure that they communicate to any other family that are involved. So this is why if we do advanced care planning early, we have the document in place and we ask the family members that we're discussing with to communicate to everyone. We're likely to avoid this, as well as the comment about utilising the palliative care service. Obviously that's within Sandwell, but better communication with family members can also avoid those calls. Jodie's got a hand up. Jodie, do you want to unmute your
Hello, thank you.
Thanks.
Yeah, just very quickly, I think a couple of questions I had was about the dementia advisors. Are they clinicians because they're working with patients from diagnosis to end of life? Do they refer on to the palliative teams, or is it that they actually put care plans in place, such as like symptom management, or are they specifically referring to sort of palliative care, which is the team that I work in?
Yeah, so some of the dementia advisors, they come from different backgrounds, and they might not necessarily be clinicians, but they do work very closely with the Admiral nurses. But the Admiral nurses tend to support the carer rather than the patient living with dementia. So what they do is they don't directly refer into palliative care, but I know that there's been some discussions that they're very keen on working closer with the palliative care hub, particularly because, like I was saying earlier, that sometimes these patients haven't got immediate palliative care needs, and it might be that they're struggling with just agitation and so on that's related to their dementia rather than related to a palliative need. So what they'll do is they'll support the patient and they'll utilise services within the community. So they'll speak to me, they'd email me quite often about patients and say there's a concern with A, B and C, and then I'll triage that to think, well, actually I'll confirm this patient and deal with that, or I will speak to one of the GPs, or if the patient is already on the palliative care register, the connected register, then I have started to email them
Because
as well.
it's a difficult one, isn't it? Because when we say that we need time for advanced care planning and when is the right time to refer to the palliative team, it can be difficult. It can be difficult to get that time right, can't it?
Yes,
to then refer into us. So it was just, it was good to know more about this, and it'd be good to work closer with them, definitely.
Yeah, and with the community Sandwell service as well, they also have a younger onset advisor, so patients that have been diagnosed with dementia under the age of 65, and also they've got rarer types of dementia such as frontal temporal disease and so on. They do start implementing some advanced care plan by using that future care handbook, so it's more about planting those seeds, and then what the dementia advisors tend to do is, depending upon what the family have said, like recently last week, Jo had emailed me to say that she'd been out to see a lady that had been diagnosed. She's got a lot of other health needs, and she started speaking about what is important to her and about resuscitation. So even though she wouldn't do the DNA test because she's not a clinician, she was able to flag that up and bring and refer them to me, and I'm going out to see them next week to advance on those conversations.
Do you think that
Thank you.
do you think that dementia it's very common in the community, and most of the general practices, they don't have up-to-date registry, in my opinion. There's still hidden so many other patients which we don't know yet actually. They are dementia, they got dementia or not. Do you think so?
Yeah, because like I was mentioned earlier about that, when we see people that are newly diagnosed with dementia that are in their early stages, and we can start advanced care planning, and that's really positive because we can involve that patient much more. But we have people that are living with dementia for much longer, so that when they are being diagnosed later on, because they might not want to do investigations earlier, is that dementia's more advanced. But it doesn't mean to say that we can't have, we need to be more positive about, actually, if we can talk to people about dementia. People often are scared that they'll feel, oh, I don't want this diagnosis of dementia, because there's still that stigma around it, where actually it's about portraying to that patient that if we can get you diagnosed, we can support you well earlier, to, like Aaron said earlier, to live well with dementia and die well with dementia, and just to get the right support at the right time.
I'd
I think
also,
one of the key comments, one of the key issues is actually identification, isn't it? In being able to give better palliative care. I think we've mentioned it in a previous talk. In all diseases, not only dementia, but identification is the first step. And yes, there are many missing patients on our lists that practices need to look at processes as how we identify those patients, whether that's using search tools, whether that's picking them up on annual reviews, whether that's looking for codes, and considering things like the SPICT tool or the GSF to consider those patients as well. So identification is key, you're absolutely right, and we are missing lots of patients in general practice, because it's such a big area. They're probably the big missing population, really. So that's the first step, and then obviously being able to do the advanced care planning once we've identified.
That's right.
Yeah. There's a couple of questions in the chat. I'm just going to pass on to Amy, who may be able to answer the questions. If not, we'll try and get the answers for you. First question is, are dementia navigators attached to each GP practice, or are they place-based?
Okay, so they're attached to towns, so there's 6 towns, so they cover Rowley, West Brom, Smethwick, Tipton, Wednesbury, and I'm not sure what the other one is, but yeah, so they're attached to areas. So if you've got a patient living in Rowley Regis, they'll be allocated that dementia advisor for that area, which is really important in building up that relationship. I think they almost become a friend to that family as well, which is really useful. And I did just want to mention about the Sandwell Dementia Community Service. You can, if you've seen a patient in surgery and you're considering referring them to a memory assessment service, you can refer to the dementia service from that point, so that they start getting support from awaiting diagnosis to diagnosis, and then continued after that.
And last question, and then I think we probably need to wrap up the questions to pass over to Anna, is how was the Dementia Navigator position funded? Do you know the answer to that?
So you know it.
I think I know it.
Okay.
Aaron,
Super.
there we go. Over to Dr. Stoney.
So I worked on this when when I was doing the mental health and dementia lead role in the CCG. It's through the Better Care Fund. So basically, that was monies that was sent from health to the local authority, but to improve health outcomes. So it's from the Better Health. It was from the Better Care Fund. And what we noticed is that we had a lot of organisations in Sandwell that were doing a lot of work with dementia, but none of it was connected. And what the third sector and the voluntary sector also found useful was everybody being given remits. And I think it's working a lot better now, where everybody they're all working together, rather than we had patients that were accessing 3, 4, 5 different services, but the impact was less. But now on the towns model, I think it's very impactful. I think the other thing with this, the connected dementia, is that if you suspect something, then they're a good place to start talking as well. So if you're feeling anything like mild cognitive impairment or anything like that, they will take on patients to have that initial chat. And the one thing for Dr. Singh is that we're trying to embed all questions about memory into anybody who has a long-term condition over 65. Same way we would ask other questions. We're asking just a simple question: are you concerned about your memory or the person that attends with them? It's just as a starter to increase our prevalence.
Thank you. I'm just going to hand over to Dr. Locke now, who's going to talk about symptom control. Thanks.
Hi, yes, so my name's Anna Locke. I'm one of the palliative care consultants in Sandwell. So this is going to be a bit of a canter through symptom control in dementia. I'm really conscious we've got people from different areas. This bit isn't so Sandwell orientated because symptom control is symptom control. And I think the first really important thing to say, and actually Amy's been sort of living this as she's been talking about it, is actually we need to do a comprehensive assessment of somebody's needs. So just because someone's got dementia doesn't mean we just think about the dementia, we just think about the whole person. And that's a whole team effort, not just the GP, not just a practice nurse. And often it really involves the family as well. When someone's dementia's progressing, it gets harder and harder for them to tell us what's happening. But there are clues. It might be their medication. It might be the subtype of dementia they have, causing them to behave in different ways. But also, I think it's really important to know who the person was before they started getting dementia, what they were like. And I think often people become more and more like they were before. So just a bit more extreme. And it's really important to know what mattered to them before. So for example, when my grandma got her vascular dementia in her 90s, she got more and more hospitable, constantly showering my children in chocolate, which was like she was before, but it was more noticeable. And I think when we're thinking about people's needs with dementia, thinking about the carers' needs is as important, because what we see in palliative care for all diagnosis really is that actually if the carers are falling apart and they can't manage, then they're going to be really in a bad place for delivering the care that they will do and need to do if that's what they want and able to. So when we're thinking about distress and pain, now people worry about pain a lot in dementia patients, because I think we all worry about being in pain, don't we? It's something that we can all imagine. Like we've all had toothache, we've all had, but actually sometimes we don't know how people are actually experiencing that pain or that distress. But actually there's lots of other symptoms you can get with dementia that can make people act in difficult ways for them and the people around them. But if we're thinking it's specifically about pain, people often can't say they've got it. We've got a gentleman at the moment who's on our list who is being very aggressive at night, very difficult. But actually he's got a necrotic toe as well. And as we're increasing his pain relief, his behaviour is calming down somewhat. The thinking about whether we need to use a tool, because actually if we've got different carers in all the time, maybe they're not going to be so systematic in the report of what symptoms someone is having, and not assuming that it's pain causing someone's behaviour. It might be constipation, which of course can be painful, or it might be got somebody else at the moment who's got a catheter that is irritating the heck out of him, and that will be causing him pain, but actually is probably also causing some of the agitation. When I mentioned tools, there are some commonly used but not well validated tools that have been used and published on. As far as I know, we haven't come round to one is the best, and I think sometimes what we do is think actually for this patient who's the best one, which is the best one to use. And the Abbey Pain Scale is the one I've used the most, and that's been that's very much about pain, and that's reported by carers. But again, coming back to, it's not always about pain when someone is agitated or behaving in a way that isn't normal for them. So for people's symptoms with dementia, really, really importantly, as clinicians, is to think about what non-drug management options might be appropriate. I've just referenced someone with pain who we did increase his pain relief, but actually we'll also be thinking about is their room right for them? Is it dark when it's meant to be night? Or actually, is it having a bit of light so they can see where they are? Important. Have we thought about basic things like regular meals or hydration? are people on too many medications? Can we actually stop some so they get less distress taking medicines? Are they getting side effects even from drugs they've been on for some time? In palliative care, we're very guilty of reaching for medications. We try not to, but sometimes it's easier to issue a prescription when you think you need to do something, and sometimes we make things worse. That's all clinicians, I think, with prescribing pads. Thinking again, particularly about some kinds of dementia, can they cause particular problems, and the medication again for those, and thinking about, can we stick to oral medication as much as possible? And we try not to do covert medication. And I think if we do that, then we really have to think carefully about how we're doing it and how we make that best interest decision in a legal and safe way. So when we're thinking about pain, first of all, and it's, to be honest, it's exactly the same for any person with any diagnosis, it's actually what's causing it. We don't always know, but we can make a best guess. Sorry, this text is a little bit small. If we're not sure whether they've got pain, but that seems a likely cause of someone's distress, then give their painkillers regularly rather than waiting. Again, very similar to somebody who's got cancer-related pain or other causes, so regular analgesia rather than waiting for their pain to get bad. We do use stronger analgesia if necessary, but all the time thinking about side effects. Could we actually make someone's condition worse? And what analgesia is likely to work for the pain they've got, because the analgesics are different, obviously. Again, thinking about whether the analgesic or the preparations can be used as topical, and are there alternative things to standard drugs that we could use? Heat pads and warm baths, if you can get people into them, I guess. And as people approach the end of life, sometimes it can be hard to know whether they're approaching the end of life and they're not swallowing, so we should use a syringe driver, so a pump with people's medication in, or whether actually we can use a patch. And we do find with some people with kind of dementia, when we think they might be dying, actually if we can manage their symptoms, we use a transdermal route, so things like fentanyl patches. But again, I would be cautious and we're starting those and thinking, actually, is it the right dose for that person? Because a starting dose of fentanyl patch is a significant dose of pain relief. For all dementia people, people with dementia, not dementia people. So planning in advance, just like we've been talking about, for eating and swallowing. Now, I'm going to show my age here, but probably when I was working as a trainee doctor, before I became a consultant, but there was still quite a lot of debate about whether feeding tubes should be used. And I'm really grateful that actually we've got good evidence now and good supporting documentation show that feeding tubes are generally not of support or help for people as they start dying with dementia. Because actually it doesn't improve their quality of life or extend their lives, because when you're dying of dementia, it's your whole body dying, not just your swallow. Thinking in advance, warning people, it can be really stressful caring for somebody who doesn't want to eat, warning people that this is going to happen and that it's normal. And I think Aaron and I've had conversations before about cultural differences and how accepting a diagnosis of dementia can be very different depending on your cultural background. And certainly some of our communities find somebody not eating and drinking well hard and challenging, and often that's the job of the clinicians and the people around them to support them, that's a normal part of dying. Mouth care, something we often forget, very basic, but having oral candida can really put someone off eating, as can having ill-fitting dentures, which can be really uncomfortable. And as people lose weight, that's often something that we need to look out for. There are some really nice feeding risk guidelines which you can get off the West Midlands Palliative Care website, and there's also good guidance on there for just managing nausea and vomiting, general symptom control. And with eating and swallowing, often thinking about reversible cause, could this person be constipated is the biggie, that we often feel like we're being very clever and unmasking, but actually it should be part of basic care. So agitation, aggression and distress. again, thinking about are there specific causes? Is someone in pain? Is the environment distressing for them? Living with someone who's agitated and not sleeping can be very distressing. We often work with the older age mental health team. I think we've all got very used to the mantra of avoiding sedatives, but sometimes when we have an absolutely shattered family, we do have to think about actually, is medication the right option to help manage the agitation and distress? And we do sometimes reach for low dose benzodiazepines or antipsychotics, but we generally do that with the older age mental health team, managing delirium, and thinking, actually, are there some special cases like Lewy body dementia where we really need to actively avoid antipsychotics? So that, I'm sorry, that was a bit of a whiz, but it's given us a couple of minutes left for questions if we've got any. I encourage everybody to look at the West Midlands Palliative Care Guidelines page, because there's lots of very straightforward information. And if you want something a bit more in depth, the Greater Manchester Palliative Care Pain and Symptom Control Guidelines have got more information again. I think it just depends what level, on how much depth you want at a time. So there we go. Questions. Yeah, I can see that Becky's been handling some questions in the chat about choice of patches when we need to, if we've got somebody who's opioid naive, we certainly wouldn't start a fentanyl 12 microgram per hour patch, and sometimes we can use a buprenorphine patch. The West Midlands Guidelines got a handy little table which shows the equivalence dose of the different opioid strengths in it. Were there any other questions in the chat, Carolyn?
There's a couple of questions, but I think you need to mute. I'm echoing there. We have responded to them in the chat. There was obviously a comment about the patch, and also Joanne mentioned the fact that her dad is unfortunately suffering from dementia, and they've had a very good support from the Dementia Navigation Service, but the GP hasn't received any update or input, and I have responded to that, say it is difficult, and I think I mean, whose fault is it? It's hard to say no, but I think that it just shows the importance of forging links with local services. So as Amy's mentioned, within YHP, she's made contact, and we've set up actually a specific email address for our palliative patients that they can use and communicate with us. So I think that is something that as GP practices, we all need to look at how we can link in, because there's no question that the NHS is changing, and NHS services alone aren't going to be enough to manage these patients. And so working out how we can form better relationships with the additional sectors and these teams that aren't actually employed or within the NHS, so they don't use the same computer systems as us. We have been having some conversations actually about how they can communicate the advanced care plan discussions, so because there's a lot of duplication of work, but we don't have the answers, and it's very difficult. So yeah, I think would it be okay for me as a practice manager to link with the service to try and get a better working relation with the team for Tipton? Yeah, absolutely. I think they'd be very keen for you to do that, to make contact with them, and that's essentially what Amy's done within YHP, made contact, and they'd be very open to that. Are there any other questions? Anna, actually, I was going to ask, I don't think you touched on it particularly, but it's quite a common theme that we see in dementia patients is insomnia. That might be too much to answer very quickly, but I don't know if you've got a quick response to that.
The really sad answer is there isn't a straightforward answer to insomnia. We have chased it before. We sometimes find simple measures like night, day cues, but sometimes people get very embedded in their sort of their switch from day to night, and a lot of it is about helping people live with it, which sounds really really sad, but actually sometimes if we give people benzodiazepines or other sedatives, sometimes they work for a little bit and then they stop working. Sometimes they make people unsteady and at risk of falling over, and that's not what people want either. And then sometimes there are tough conversations about whether actually home is feasible for the long term or this medium to short term, and whether actually 24-hour care is more able to manage. A lot of it will depend on the family setup, but you know, there are sometimes the old age psychiatry mental health teams suggest things like sedative antidepressants. So if anxiety is a big part of what's going on, if they seem to be very scared, then they might suggest mirtazapine. Sometimes we get suggestions for risperidone or haloperidol. Sometimes they work, sometimes often they don't.
Thank you. There's a comment from Joyce. I'm not sure what you're referencing. I don't know if there's a second, the first part is missing. I don't know if you want to come in there. You've said he gets up out of bed up to more than 10 times a night and is unsteady on his feet and doesn't know who's doing this.
Joyce, is that your family member?
Yeah, it's my father.
Yeah, I am. We probably can't answer that on this. Have you spoken to? I wonder whether going back to your family doctor to talk about it would be an
Yeah,
option.
he's been doing this. I mean, he's 94, but he's been doing this now for, oh, what, 18 months, 2 years. And sometimes, like, you put him to bed and you think he's comfortable, and then like 30 seconds, a minute later, he's climbing out of bed again.
Yeah.
And this can go on numerous times.
Yeah. And are you from the Scottish borders?
Yes.
Yeah. I'm sorry, you are a long way from us. I think you probably need to sit down and go through it again with someone who's a healthcare professional near you who might be able to carry on supporting you.
Yeah, I mean, we have tried him on melatonin, and we have increased that now to 4 milligrams. We did try him with haloperidol, but the haloperidol didn't have any effect whatsoever. Now, I'm not sure whether that was because it was liquid, and he's got terrible drooling, and so whether or not the haloperidol wasn't actually being absorbed and he was just like drooling it out again, then that may have been the issue.
I think it might be worth going back to family doctor and just saying this hasn't worked. What other support can I have with this? Who else might be able to give some advice, whether it's the local elderly mental health team or whether it's a palliative care team. It'll depend on how things are set up. Joyce, I'm really sorry. I'm really sorry.
No
I can't do this in this.
That's okay, no problem. Thank you.
Okay. Carolyn.
Thanks, everyone. I think we've reached the time now. As you can see, there's a, I've forgotten what it is. My brain's not working. QR code. If you could feedback, that'd be really helpful. If you do require a certificate for your attendance, can you use the email address that's on that slide? So I don't know if you want to take a screenshot or something and let us know. Thank you.